Thank you very much, Mr. Deputy Speaker. I'd like to bring to the House's attention the condition known as phenylketonuria and the drug sapropterin, which is known as the trade name Kuvan. And before I start, I'd very much like to thank the member for Spelthorne for being here tonight. He raised this same matter in an adjournment debate 6 years ago. The Parliamentary Under-Secretary of State for Health, another fantastic Essex MP, thank you very much, and the member for Strangford, who I know has also got a constituent with the condition. I co-chair the All-Party Parliamentary Group for Rare Diseases, but I also raise this issue primarily as a constituency MP. This is my first adjournment debate, and I'd like to discuss the case of one of my youngest constituents. It was at one of my first constituency surgeries that I met Natasha Cotter, and she told me about her daughter, Kate. Kate and her father are in the gallery this afternoon. Kate has phenylketonuria, otherwise known as PKU. It is very, very rare. I'm sure all of us who are parents remember those first moments when our newborn baby is in our arms and then the child is taken away and given that heel prick test. And for the vast majority of children, the test comes out clear. But for 1 in 10,000 babies, the test will show that the child has PKU. And without treatment, these children can become very suddenly, very seriously, very ill. People with PKU cannot metabolize phenylalanine. This is an amino acid found in protein, and if not correctly treated, the amino acid can build into levels that are toxic to the brain. If unmanaged, PKU results in severe and irreversible brain damage, and the treatment for these children is to remove almost all natural protein from the diet. My constituent Kate is 10 years old. She can only metabolize 11 grams of protein a day. She is restricted in every eating experience of her life. Her day is ruled by limited food and constant protein supplements. These drinks taste foul and smell unpleasant. And when other children can share a meal, perhaps a birthday cake or a piece of chocolate, Kate can only have her protein drink. Her parents tell me that she is permanently hungry. They say that every day since she was born has been filled with the joy that she brings, but also the misery associated with the daily management of a lifetime condition. The severe restrictions that PKU diet places a great burden on parents and their families. The phenylalanine content of all food needs to be really carefully restricted. Even vegetables like potatoes and cauliflower have to be restricted. And Kate's grandmother has given up work to care for her. In fact, research shows that over half the carers of a child with PKU have either stopped working, reduced their hours, or changed their jobs so that they can just help manage that diet. And unsurprisingly, the constant worry about what the children are eating and whether or not the brain damage may be caused by just everyday food puts a huge emotional strain on families. And a recent study found that 59% of the mothers caring for PKU children had clinical levels of psychological distress themselves. Furthermore, problems with learning difficulties are frequently reported in children with PKU, and a survey of families found that 43% of children had problems staying focused at children, and 30% reported that their child had either depression or anxiety. But, Mr. Deputy Speaker, there is hope. For a month, Kate was put on the trial of the drug sapropterin. It's a drug made by Marin and marketed under the name of Kuvan. And during that trial, Kate's ability to metabolize the phenylalanine increased threefold, from 400 milligrams a day to 1,200. That's the equivalent to 24 grams a day, and that allows Kate to eat a normal vegetarian diet. Her parents have told me how she was a different child, so happy to be able to eat real food. Even a visit to the supermarket was a real adventure. Her mood lifted, the nightmares stopped, she increased in alertness. Her teacher asked what had changed because she was a different pupil at school. So sapropterin is the only licensed non-dietary treatment for PKU, and it doesn't work for all the genetic variants of the condition, but it works. It benefits about 20 to 30% of sufferers, and this is a really, really tiny number of people. About 150 children in the whole country. Children and adults are less than 350 in total. It is so rare. But for people like Kate, this drug is life-changing. Sapropterin is available in Austria, Belgium, Bulgaria, the Czech Republic, Denmark, Estonia, France, Germany, Hungary, Italy, Latvia, Lithuania, Luxembourg, the Netherlands, Norway, Portugal, Romania, Russia, Slovakia, Slovenia, Spain, Sweden, Switzerland, Turkey, and in Ukraine. It is also available in the United States of America, but except for a small number of women in pregnancy, it is not available in England on the NHS. I've written to the Secretary of State for Health and Social Care to draw Kate's taster's attention. I also wrote to my local NHS clinical commissioning group, and they sent me to NHS England. NHS England recommended an individual funding request. But for an individual funding request to be successful, the patient has to be considered exceptional. And so far, only those with additional conditions have been able to access the drug via this route. The patient has to prove that they have PKU and another condition. But how likely is this? I mean, these PKU children are exceptionally rare. There's only 150 of them in the country. They already are exceptional. And for patients like Kate, this is an impossible barrier. In fact, I've been told that only 3 patients have ever successfully managed to get prescribed the drug through an individual funding request. Last summer, NHS England said that they would review the decision on sapropterin. Last month, NHS England wrote to the patient organisation, the National Society for PKU, and they said the decision would now be made by NICE, the National Institute for Health and Care Excellence. And last week, the patient organisation wrote back to NHS England because it's not clear to them what process will be used or when the decision process will begin. So, Mr. Deputy Speaker, I understand that funding for all treatments is not unlimited. Decisions do need to be made in a rational manner. But patients with PKU believe that as well as the positive health benefits, there are also positive financial benefits to the public purse from commissioning this drug. The NHS estimate that Kuvan could cost between £14,000 and £45,000 per patient per year. But BioMarin, the manufacturer, have told the patient organisation that they are willing to make substantial discounts. And furthermore, that price will need to be weighed against the cost of not having the drug. For adults, the protein-restricted diet alone costs the NHS £12,000 a year. The average cost to the taxpayer of each parent who gives up work to care for their child would be another £5,500. A third of the children need additional help at school, and the cost of that varies, but the typical notional budget for a child with SEN is another £6,000, certainly.
Deputy Speaker, I thank the Honourable for giving way, and I'm not normally here for the German debate on a Thursday afternoon, but because of the timescale and because of the issue and the party's health spokesperson, I'm very interested in this subject as well. The Honourable is very passionately, very detailed, very forensically outlined the case for the need to have this drug available. Sometimes it's not just the person who needs it, it's the family who needs it as well. There's the mental impact, there's the physical impact, and I support the Honourable Lady's request to the Minister to make it happen for 150 people for a small price, which, as the Honourable Lady has said in her contribution near the end, when you add it all up, it's worth the price of good health for a child and for an adult.
Thank you very much for your comments on this, and I completely agree that we need to look at the wider issue. And in fact, we also look at what happens if the condition is not successfully managed, because then it can be even more difficult. For example, if a woman with PKU gets pregnant and the condition's not well managed, the child that they bear has a very high risk of having substantial long-term disabilities themselves. And if a child with PKU doesn't manage to stick to the diet, then they're at risk of permanent brain damage. And it's all those wider costs that I think should be taken into consideration when making this assessment. The patient organisation is very concerned that NICE may decide to restrict the drug and only offer it to what they consider high-need patients. So therefore, the drug would only be given to those patients who have refused to follow that strict diet, and it would discriminate actually against those who've done the right thing and worked so hard to maintain that very difficult dietary control. So please, Mr. Speaker, Minister, let's try and break this deadlock. BioMarin and NICE need to engage with each other. They need to do so in a transparent way that has the full support of the patient organisation, and the whole patient population should be considered. Those who do with the right thing with their diet should not be put at a disadvantage. I also think this is a bigger issue, Mr. Speaker. Just promoted you. Mr. Deputy Speaker, not just a debate about one patient or one drug. There's a wider point about how we in Britain approach new medicines and new treatments, especially for rare diseases. We are a world leader in science, especially in the life sciences. We were home to the Human Genome Campus. That amazing, visionary 100,000 Genome Project set us at the forefront of the global revolution in medical research. Furthermore, our unique NHS gives researchers the ability to access very large quantities of reliable data, helping them to identify very, very specific genetic divergences. And that means that medics can increasingly just pinpoint the very exact cause of rare condition and tailor specifically which one of a new generation of personalised medicines will give the most effective treatment for that condition to that individual. And life sciences is right at the heart of the government's industrial policy. But if we are to stay at the forefront of world medical research, then it's vital that discoveries are not only made here, but they're also trialled here, tested here, and prescribed here. NICE is a world leader in assessing medical health technology, and many countries have chosen to follow its approach. But the world of medical research is changing at an exponential rate, and if it's to hold the confidence of the researchers, the physicians, and the patients, it must prove that it can evolve and evaluate even the most innovative treatments, especially advanced medicines, cell therapies, gene therapies. And when NICE does approve a new treatment, we need to make sure that the NHS can commission it effectively. So I'm told that today the NHS can't commission a drug unless it's been to NICE. Before the drug is given the marketing authorisation, there's the option for the company to make it available through the Early Access to Medicine scheme. But after that marketing authorisation and pre the NICE approval, there is no route to funding except through those individual funding requests. And so, as the Minister knows, these rare diseases are very, very rare, or at least some of them are. And the overall cost to the NHS, therefore, is really a very small part of the budget. We do need to find a better way for all parties to work together to facilitate the passage of orphan drugs for very rare conditions through NICE and through the commissioning process. So thank you all, colleagues, Mr. Deputy Speaker, Ministers, for listening to my comments this evening. Thank you to the Cotter family for being here. Britain is a world leader in medical research, and let's make sure that British patients, like my constituent Kate, can be among the first in the world and not the last in the world to benefit from medical discoveries. Thank you.
Minister.
Thank you, Mr. Deputy Speaker. And can I also thank my honourable friend, for the member for Cheltenham, for the very... Sorry, I corrected it on my brief. I know she's Chelms, but I ought to know she's Chelms, so she's a near neighbour of mine. But to thank her, actually, for the very passionate and articulate way that she's made her case this afternoon. I'm actually very proud that it's me responding to her first adjournment debates, because she and I go back a very, very long way. So can I thank her, and I hope to give her some comfort about the fact that we are taking into consideration some of the issues that she's raised today. Can I also thank the Honourable Gentleman, the member for Strangford, who again made a very articulate pitch on behalf of the families of people who are suffering from rare diseases. And we do need to always remember that when dealing not just with the person with the condition, but the burden on their family can often be as great, if not greater. So we do bear that in mind. So my honourable friend, the member for Chelmsford, has raised this debate on phenylketonuria and treatment with Kuvan, setting out on behalf of all PKU patients their concerns, which I hope to address. The importance of addressing rare diseases, of which PKU is one, is increasingly recognised by policymakers and healthcare service providers, not just in the UK, but worldwide. Mercifully, the numbers of patients suffering from each rare disease can be small, but collectively 3.5 million people in the UK alone are affected by rare diseases. And to put this number in context, this is 1 in 17 people who will suffer from a rare disease at some point in their lives. So the government is dedicated to improving the life of patients with rare diseases. This is laid down in our promise to implement the 51 commitments of the UK Strategy for Rare Diseases, and that includes the need to take account of new evidence that may emerge as a result of research and development. Now, many rare diseases are present at birth or soon after, and PKU is no exception. We understand that PKU has an estimated prevalence of 1 in every 10,000 births, and we know that without treatment early in life, the outlook for those born with PKU is very poor. Without appropriate treatment, as my honourable friend has outlined, people will develop severe learning disabilities, which may lead them to require constant care. But with treatment, the outlook can be good. Screening, therefore, has a vital role in early and accurate diagnosis. The current newborn screening programme in the UK is based on the blood spot or heel prick test and screens for 9 rare conditions, including PKU. Treatment can then start straight away, minimising the risk of serious complications. As I understand it, for patients with PKU, this treatment includes a special diet, confining intake to low-protein food and regular blood tests, as my honourable friend has explained. Now, I do recognise that this protein-restricted diet can be very limiting and particularly difficult for children to adhere to. Young patients with PKU cannot eat many of the enjoyable foods that we all eat each and every day, such as meats, milk, cheese and fish. So undoubtedly, this does put a strain on patients like Kate and their families, and I'm very pleased that they're here witnessing this debate today. It can make simple day-to-day activities like going to school or meeting friends a significant challenge. And I also appreciate the immense pressure it must put on parents and carers to stop a child from the pleasure of choosing and eating a wide range of food on a daily basis. We all understand the desire of young patients to live a regular life, eat any food that they like and not have to worry about the consequences. But because of the extremely limited number of naturally low phenylalanine foods available to PKU patients, mainly fruits and vegetables, they also need supplements to meet daily energy requirements, add bulk to their diet and increase variety. And my honourable friend has outlined some of the protein shakes that they have to rely on to do this. The availability of those low-protein foods and nutritional supplements through the NHS is still very important and has, since its development by Birmingham Children's Hospital in the 1950s, saved the lives and improved the outcomes of many PKU patients. But let me move on now to address specifically the point she's made about the medication Kuvan, which has been found to lower blood phenylalanine levels in some patients with mild or moderate PKU. As highlighted today and in previous debates, this drug is unfortunately only effective in some patients, and that is entirely dependent on their particular genetic makeup. It is most likely to benefit those with milder forms of PKU, and in those cases where patients respond to treatment with Kuvan, it means they're still likely to be required to continue with some form of dietary restriction. So NHS England currently has a policy on the use of Kuvan for the management of PKU during pregnancy, and it's targeted to patients who are not able to establish low levels through dietary control alone. Keeping mums-to-be safe is of great clinical importance to prevent maternal PKU syndrome and lifetime adverse consequences to their babies, the worry of which may further increase a mother's anxiety around pregnancy and the worry about their developing baby. The reason Kuvan is currently not routinely commissioned for use in children and adults is due to the lack of evidence of its effectiveness on nutritional status and cognitive development at the time the policy was developed back in 2015. However, if doctors treating a patient think they would benefit from treatment with Kuvan, clinicians are able to make an individual patient funding request, as my honourable friend has said. Now, I appreciate that what she's asking me for today is for a bigger change than that, beyond access for an individual patient, namely a wish to see a change in the commissioning policy on Kuvan for the use in children and adults that respond to the drug. As I've mentioned in my opening remarks, it is important to take account of new evidence and developments as they emerge. And I'm happy to report that NHS England has received a preliminary policy proposal for the use of Kuvan in the management of PKU for adults and children, as new evidence has now been published to support its use. This was considered by the clinical panel in January, where it was agreed that NHS England should undertake a further review. NHS England is now working with NICE to agree the best approach to this, and has asked NICE to consider developing advice on the use of Kuvan. I hope my honourable friend will accept this as a positive step in the right direction. I also agree with my honourable friend about the need for good stakeholder engagement. Taking stakeholder views into account is vital in any decision-making process, and that will involve members of the public and patients, including Kate and her family, and all families who will be impacted on this. I'm very pleased to hear the point made by my honourable friend that BioMarin, the manufacturer of Kuvan, is very open to negotiation on the pricing of the drug. That's extremely welcome news. And indeed, as part of any review process, manufacturers will be able to offer a patient access scheme to NICE, and the price offered is then considered to determine the cost effectiveness of the drug. So I do hope I can reassure you today that discussion on access to Kuvan is actively being considered. The Department will follow NICE and NHS England's upcoming work with great interest as they consider the impact of new evidence on commissioning policy. I just want to emphasise that research is crucial to improve our knowledge of rare diseases and to work towards better treatment of them. And I'm pleased that the UK is recognised as one of the leading countries for research into rare diseases. And in July 2017, the Chief Medical Officer published her landmark report setting out a vision for genomic medicine in the UK. The government has accepted that report in full and responded with the establishment of a National Genomics Board chaired by my colleague, Lord O'Shaughnessy. I hope this reassures my honourable friend and the House of the government's real commitment to support research aiming to bring real change to the way we understand and treat rare diseases. We are in a fantastic position in the UK at the forefront of that science, and it is our patients that play such a vital role in challenging us as policymakers, as healthcare professionals and researchers to find new treatments for the benefit of all. So to conclude, in going forward, we will ensure that we harness the remarkable prospects that these new developments present for the benefit of our rare diseases patients. We will look more closely at Kuvan. NHS England and NICE will be reviewing the new evidence and will engage with BioMarin to consider whether Kuvan should be made available more widely. I'm very grateful to my honourable friend once again for highlighting these issues, and perhaps through her, as I close, I extend my very best wishes to Kate and her family as she battles with this disease.